Hi, everybody. My name is Nishi Singhal. I'm the program officer at the Texas Primary Care Consortium. I'm really excited to bring to you today's monthly Monday Primary Care Talks. This show is dedicated to interviewing guest speakers from all over Texas, covering a wide range of primary care topics. Each month, we will bring you informative episodes, really as your go-to resource on all things primary care. So today, we will hear from Dr. Laurel Williams. She's a professor in the Department of Psychiatry and Behavioral Science at the Baylor College of Medicine. She's also the medical director for the Centralized Operational Support Hub for the Texas Child Mental Health Care Consortium, coordinating the implementation of a statewide child psychiatry access network and a telemental health to youth in schools. I'm really excited because we will get to hear more about this today. Dr. Williams is also the training director for child and adolescent psychiatry at Baylor. Her special expertise is working with the youth who have suicidal and self injurious behaviors, as well as pregnant and postpartum adolescents. Let's go to the show. Thank you, Dr. Williams. Thank you for joining us today. I want to start off with really just hearing from you, a little bit about yourself, your background, but also how your work impacts the primary care system.
Well, thank you for letting me come here today and share with you a little bit about myself and sort of the work that I'm doing. I wasn't born in Texas, but I got here as quick as I could. But I've lived in Texas pretty much all my life. I went to school briefly outside of Texas for undergrad, but I came back to medical school, went to North Texas. And one of the things I really, really appreciate about my education at TCOM was the sort of idea of the primacy of the relationship and the whole body approach to care. And if I hadn't become a child psychiatrist, I would have been a primary care physician, because I really do believe in that primacy of the relationships that we would hope to build over many decades of somebody's life in primary care. So I think that that's really important. And, my father is a physician and he is also a family practitioner. He retired right before the pandemic hit. But as soon as he got his shot and was safe, he went back to doing volunteer work. So who I am is a lot of who I've seen my dad and how he practices, and how, he would call people at 8 o'clock at night to tell them their results were routine and normal. He didn't leave that to a nurse. It really instilled in me this idea that people trust you, and they're looking to you for the answers. And obviously now there's things like Google everything, so you can find stuff out, but you want to hear it from a trusted source. And so in my work as a child psychiatrist and a general psychiatrist, people come to tell me all kinds of things that are very difficult and challenging. And I have to have that safe space for them. And I think that's still equally important in any aspect of medicine, but particularly in primary care, that this is a place where people can go to feel comfortable. And that takes time. You don't necessarily, the very first time you meet a physician, tell them everything. And so being able to have ability to come back over time and then a little bit more, feel like you can trust, and then say a little bit more, that to me is what's so critical about primary care and primary care physicians. And what I hoped, even though I'm a child psychiatrist, what I hope that I do as a child psychiatrist. Now, in my role, while you're talking to me today, like while you're talking to some random child psychiatrist, is that I'm the medical director for the Child Psychiatry Access Network, that's available to all primary care physicians across the state to sort of help them with mental health issues that they may be having with either young babies, like, kids from 4 to 20, and then also for women who maybe are pre or postpartum and who are struggling. So we help both children and adolescents, but also women. And we really hope that what we do is can kind of be an extender of their our expertise to them, so that we can help them do more in their practice, and they don't necessarily need to refer to a specialist. One of the things we really have discovered in some of the research, not just in Texas, but outside of Texas, is these kinds of access networks actually help physicians have a better trusting relationship with families. because they trust their physician that they've been working with. And so if that physician recommends something, they're more likely to follow it than if they were to just be referred over to a specialist sometimes. So we really see this as a support to the primary care doctor, but then in the end, who is it helping is also helping the child, the adolescent, the mom that's in front of them in their own practice.
I love that. And I love that you talked about how primary care physicians really are the source of trust, and you have to create that trusting relationship. We had recently, spoken to three different patients, and that was both what they liked about their primary care clinician, but then also what they hoped for more of. And so I love hearing that both from the clinician point of view, but then also, of course, from the patient point of view too. And you kind of touched on this, but in your words, how would you define primary care? I know this is something, that we're looking at internally, especially as we're setting primary care in the All Payers Claims database. But just generally, I guess, how would you describe primary care to any person on the street?
To me, primary care is the first place that I would hope a person would go when they have a concern about their body or their mind. That maybe they don't exactly know what's going on yet, and maybe they resist the urge to Google or do a WebMD search, and instead go and speak to somebody who is knowledgeable about all the systems of the body and is also knowledgeable about you. So then they might be able to help you navigate. Maybe this is something that we can just manage in primary care, and we don't need to search elsewhere. But if it is that you need to go somewhere else, that the primary care physician or team, because it's becoming more of a team sport, you know, is that they can help keep the source data all together so that you're kind of paying attention to, well, the neurologist said this and the rheumatologist said that and the urologist said this. And as primary care, I'm getting all those reports and I need time to synthesize it. I need time to be prime so that I can then sort of help that person navigate their health. And so I think that does mean that there is room for a team in primary care. And we don't have to do it exactly the old school way that my dad did it, for example. But at the same time, the physician is still the center because they have taken the necessary years of dedication in education to really have a very deep bench of knowledge so that you could still deploy your other team members in your primary care team. But the physician, I still really do believe, needs to be kind of core. And with that, they need to have that time available to them to synthesize. So primary care to me doesn't mean seeing a patient every 10 minutes and then collapsing in a heap at 5 o'clock, only to go back after dinner and write 20 notes. Like, because you're just trying to tread water, keep up. We really need to put the word prime in all of our attempts to help reconstitute what our healthcare system is going to look like, to give those physicians back some time to do that sort of synthesis, even if they're going to hand off certain components of it to different members of their team.
Yeah, I love that. Actually, just curious on that as you are working directly with primary care physicians. And as you said, patients love to hear referrals directly from their primary care doctor. And so when they do come to see you, do you feel like you already kind of have that initial, as you were talking about before, that trusted, or I guess the patient's trust? Or do you feel like there's a little bit of, I don't know, like education that sometimes a primary care clinician that you would want them to, have with their patient before they come see you?
I think mental health is, as much as we've been making progress and sort of stigma, I feel that there's still a fair amount of stigma that people come to me and they're worried about things and so worried that I'm going to say something that they're crazy or their child's crazy or somehow they're a bad parent. That's a really big one for us, is that parents feel very shamed sometimes, even when there's no shame, but just, people are concerned that they're going to hear a judgment about how they're sort of helping their child. It's not that I think I'm reasonably good at helping people and educating them, but I still don't think that everybody comes to me trusting because they're worried that I'm going to say something that might feel really challenging or negative, just because of all the stigma and sometimes the bad press that mental health still kind of gets. The movies all continually treat us as either inept
Mm,
or sadistic, one of the two, right? So it
right,
can feel difficult to fully trust in that first visit with even with me, and that's okay. Like I don't tell people that they should trust me right away. But I think that's why there's so much more success to be had in the space of mild to moderate mental health challenges to be managed in primary care, because hopefully you have been able to build up a little bit of a relationship. So if you were to recommend something, and
right.
particularly if you were to say, you know what, let me go check my sources, let me go talk to my experts, and then I'm going to come back to you, mom, and talk to you. That shows the mom that you really care. That shows the mom that you're thinking about her and her child, even when they're not in the office with you. And
Hmm.
that it's just that simple fact of saying, I'm going to go talk to an expert and get back to you, makes the person feel even more like, oh my gosh, this person really is understanding. And that sort of just really builds up the trust even more. So I don't know that I think primary care physicians need to do more to help me get my start with my relationship.
Right.
I think that one of the reasons why I'm doing CPAN in part is because my dad was always fussing that he could never get a psychiatrist to call him back.
Mm.
So it was more, and again, I'm not trying to make all psychiatrists look bad in this statement, but my dad was like, I could never get them in to be seen. And if they did get seen, I never got a call. I never got a note. I didn't know what was going on. And I
Right.
was just kind of left in the dark. And then the parent or the mom or the person was asking me all kinds of questions. And so this collaborative care model that CPAN is this idea like, I'm going to talk to you as a physician to physician. You're going to get to hear how I might think about the case, what I might recommend you do about it. And at times, if it's necessary, our team will see the patient one time to get a diagnostic evaluation done, so that even if the patient is going to come back to you in the primary care, we now have a shared understanding about the patient because our team has seen them once, right?
Hmm.
So I think that can be very, very helpful in sort of that concept of building and maintaining trust, is that we actually are available when you need us, not when we want to talk to you, especially.
Right. Yeah. So I guess related to that, is there a primary care challenge that you're currently working on alleviating, or I don't know, maybe it's something in your clinical practice that would be helpful if there was a change in primary care that would then help you.
Well, again, the biggest thing that for the longest time, the head was not attached to the body. Mental
Mm,
health, because of this just a huge stigma that was around mental health, is that we actually used to wall it off from the chart. Like you couldn't see the notes from mental health from the rest
mm,
of the body. So we really had this weird relationship with our minds and how it interacts with the patient themselves, but then with other providers around it.
right.
So I think what we're trying to solve is partly physicians graduate from residency not having done very much mental health, because it's been sort of walled off and thought to be so much more mysterious and complex than anything else, that it's
Hmm.
kind of made it almost where we've made people scared to try, and scared to use a lot of the skills that they would use in other sorts of parts of the body still hold true for your brain and your mind. But we've made people feel like, oh my God, the only person who can do this is somebody who's had 5 years of training in child mental health. I shouldn't even attempt it in primary care. But what we know is 30 to 40% of primary care visits involve mental health.
Hmm.
So training needs to change, and ACGME, the national body for training, is starting to make some inroads in that process, but even that is still decades down the road because so many physicians did not leave training with adequate training in mental health. So what I do in my role at CPAN for the state is that we are that team that can help a primary care physician in Texas today get some additional education, additional knowledge, over time develop some skill, see the outcomes of their interactions and their decision making, and get basically almost in simultaneous support for those decisions that they're making. You can call about the same patient as many times as you need to
Hmm.
help that person. And while we're doing that, while we're helping that one patient, we're also teaching that physician. It's a very common way that we teach physicians. It's see one, do one, teach one. So I might sometimes I might need to see one myself and then tell you what to sort of how to help. And then we also have education opportunities where you can just learn some things around mental health separate from one particular patient. And then over time, as I taught you how to do it, you start as a physician doing it yourself. And next thing you know, you feel comfortable with sort of, let's say, mild anxiety or moderate anxiety. And now you feel like, I know what, I might be able to do something related to OCD.
Mm,
So we take people where they are. And if you have very little knowledge in mental health, we just stepwise you till you feel more comfortable. If we get some physicians like, well, I've been prescribing SSRIs for 10 years, but when it gets to, alpha agonist and ADHD stimulants together, no. They start being able to do some of those things. We know that they have the capability because they do it with things related to pulmonary, with neurology,
right.
with endocrine. Like they're used to being able to do complicated things in primary care with the other body systems. They didn't get enough education in their residencies to feel comfortable to do it in mental health. And that's what CPAN is helping to rectify.
Hmm. I love this. I'm as you're talking, I wish there was a similar kind of network with all different types of you know, clinical services, but even non-medical drivers of health type of services too, because I think as you're saying, this is what clinicians really want, or even as you described your father, that this is what he probably would have liked, right? Was to have this network of almost like a directory of people that trusted people that you could call.
Mm-hmm.
I love this last question, which is if you had a magic wand and if you could change anything about the primary care system in Texas, what would that one thing be?
It's really about money. I mean, I don't know if this is a crass thing to say, but we've decided a long time ago the fee structure for a lot of things. And again, this is not to take away from other specialists, which, by the way, in psychiatry, we're also one of the lowest ranked specialties for how much we get paid. So I'm not one of those necessarily another specialist that you potentially would say, I'm taking away my own business, I guess. But we have a really weird system, in my opinion. And it's not rocket science as to why my dad had to see a patient every 10 minutes. It's about just actually some really basic simple economic facts. And I think that one of the challenges is alluded to is this idea that the only person that makes money in a practice is the physician, your nurse, your health coach, so several other people that need to do things to help the patient. We don't have a charge for them. So the charges almost always completely rely on the physician seeing a patient. And
Hmm.
so if we keep having the primacy be about this sort of CPT coding that we do and how things are decided, how much things are worth, I don't think we're ever going to dig ourselves out of this hole. It does feel like it's a smarter brain than me. Like I've not figured it out. Like I'm not here to tell you that I figured it out, but I see how it works. And so, for example, a lot of people fuss because psychiatrists do a lot of fee for service. They don't do insurance. Well, it's because of the simple economics of it. If I need to see a patient for 40 minutes, 15 minutes, I can't survive on Medicaid alone or United Healthcare or Blue Cross Blue
Right.
Shield because the reimbursement rate is like $50.
Hmm.
Right?
Yeah.
So, and then I had to hire three people to manage that claim, right? To get that
Yeah.
$50.
Yeah.
So it's not mysterious, in my opinion, about why a physician in family practice is working themselves to the bone. It's economics. It's the economy. I think I'm not going to use the next word that Bill Clinton used, but it's the economy, that is kind of where we are. I wish I knew how to fix it. I know that some of the things people have been talking about are obviously raising rates, adding more types of codes to kind of allow for more flexibility. To me, it just starts to feel like, okay, now there's another thing you're making the very busy physician have to account for. So
Right.
I'm a little leery of some of those ideas because I already know how much pain there is in the EMR system and all the little dots and things you have to dot and cross to
Hmm.
get your $50. So I don't
Right.
know that I would want it to be about, here's one more thing I have to write down that I did, so you'll give me a little bit more money.
Mm-hmm.
But it's
Yep.
money. It's really, it's about the economics of it.
Yep. Now that makes so much sense, and that it's really why, the consortium is really wanting to do more on this. As we're connecting with different stakeholders, of course, getting more into collecting different data sets and kind of research on what's working, but also what's not working. So,
That being said, we have put out materials to physicians, because if you call CPAN and talk to us, you can appropriately bill for the time that you spoke with us. I'm not claiming you're going to get a lot of money back, but you can, write down with some reasonably brief phrases, and it allows you to appropriately bill for the time that you were working for that patient, for that family. So we certainly provide that information to physicians, but I don't know how much that you actually get made. I'm just going to say, let's say it's $10. Well, I know that $10 still doesn't necessarily cover everything that you had to do that day, but it's not nothing, right?
right.
So if we're going to keep playing through these rules of CPT codes at the wazoo, absolutely you can use the appropriate codes, whether it's complexity based or time based, when you have a consultation with CPAN.
Yeah. Awesome. Thank you so much. We
Sure.
we really appreciate meeting you today.
Mhm.
And of course, people will have your contact information. So if they have any
Absolutely.
more questions and just want to learn more,
Mhm.
and be able to connect with you. So
Yep.
thank you so much. And looking forward to continuing our work together. Thank you, everybody, for tuning in. We'd love to hear your thoughts, your questions, and any feedback that you have for us. You can go ahead and reply to this email with your thoughts. And of course, you'll also find Dr. Williams's contact information if you have questions for her or just want to connect with her about her work. Thank you so much. And this has been the Texas Primary Care Consortium's monthly Mondays Primary Care Talks.